English version. Hello everyone, I'm Juan Le Rumeur, a physiotherapist based in Paris, specializing in pelvic health. Welcome to this new weekly pelvic health review. This week the main dossier focuses on postpartum perineal trauma, how to follow it properly without dismissing it but without catastrophizing it either. The secondary thread will focus on pelvic floor rehabilitation, learning how to contract, checking the quality of the movement, and then training. We will finish with short clinical briefs on fecal incontinence, pelvic toxicities, sexuality, pelvic pain, and prolapse surgery. Dossier of the week: perineal trauma, neither dismiss nor catastrophize. The main paper is a systematic review and meta-analysis on prognostic factors for wound complications after childbirth-related perineal trauma. The strongest signal is clear. Assisted vaginal birth is associated with wound complications. Raised body mass index was not significant in the pooled data. Other plausible factors, such as smoking, episiotomy, and prolonged second stage of labor, remain insufficiently studied or too heterogeneous for firm conclusions. The reasonable clinical message is to target follow-up after instrumental birth and perineal wound trauma without turning every theoretical risk factor into a clinical certainty. The second key paper immediately adds nuance. In a Swedish follow-up of a randomized trial, 1,911 primiparous women were assessed 1 year postpartum with the PFD-I-20 questionnaire, the PFIQ-7 questionnaire, and specific items, and pelvic floor symptoms were common. But minor and major second-degree tears were not associated with increased pelvic floor dysfunction or reduced quality of life. Obstetric anal sphincter injury, however, remained associated with increased colorectal anal distress. This is clinically useful because it prevents a common drift, confusing the existence of a tear with an automatic poor prognosis. One patient may recover well after a second-degree tear. Another may have major symptoms after an apparently minor lesion. Follow-up should therefore be guided by symptoms and risk factors, not only by the obstetric label. Fecal incontinence deserves its own place in the postpartum discussion. The Tuscan longitudinal cohort followed more than 10,000 women from pregnancy to 12 months postpartum. Fecal incontinence remained relatively uncommon, with prevalence in the low single digits, peaking around 3 months postpartum and decreasing by 12 months. Wexner scores were generally modest. This does not support alarmism, but it does show that the symptom exists and may already be present during pregnancy. The practical point is simple: ask about it. Not once vaguely at the end of the visit. Ask again over time, especially after assisted birth, obstetric anal sphincter injury, pain, wound problems, or anorectal control complaints. Long-term data complete the picture. A Swedish matched cohort of women aged 40 to 64 found more fecal incontinence after 2 vaginal births than after 2 cesarean deliveries. The risk was even higher with a history of obstetric anal sphincter injury. Age also contributed. This must be read at the population level. It does not predict the future of an individual patient, but it reminds us that obstetric injury and aging can meet years later in anorectal complaints. It is a reason to document obstetric history in midlife anal incontinence assessments. It is not a reason to frighten every woman after vaginal delivery. Urinary symptoms are not strictly perineal wounds, but they belong to the same postpartum triage logic. In a nested case control study of 408 low-risk women after vaginal birth, 20.1% reported lower urinary tract symptoms on postpartum day 2. About 43% of symptomatic women still had symptoms at 6 weeks. Associated factors included prolonged second stage and higher birth weight. The message is not to pathologize day 2. It is to avoid premature reassurance. Very early urinary symptoms may resolve, but they deserve information, monitoring advice, and follow-up, especially when other perineal warning signs are present. Pain is also part of the dossier. The review on postpartum pelvic girdle pain shows that emotional distress is associated with persistent pain. But the more interesting signal is that positive recovery expectations appear protective. This should not be used to blame patients. A patient does not recover simply because she thinks positively. However, clinician language, prognosis explanation, graded return to movement, and avoidance of catastrophic beliefs are probably real levers. In postpartum care, words matter. They can reassure and mobilize, or they can freeze the recovery trajectory. The final postpartum paper concerns topical vaginal estrogens. The systematic review found only 3 studies, including 85 women in total. There are possible biological and symptom signals regarding postpartum atrophy, with acceptable tolerability, and no major safety signal in these limited data. But efficacy on urinary, bowel, or sexual function is not established. This is a paper for caution. It opens a clinical question: relative hypoestrogenism, lactation, vulvovaginal tissues, and dyspareunia. But it does not make topical estrogens a standard postpartum answer. The final message of the dossier is therefore twofold. First, risk must be stratified: assisted birth, obstetric anal sphincter injury, wound complication, anorectal symptoms, persistent urinary symptoms, pelvic girdle pain, and poor recovery confidence should trigger closer follow-up. Second, stratification is not catastrophizing. Not all tears are equivalent. A second-degree tear is not by itself a poor prognosis. The clinical goal is to follow a functional trajectory rather than attach an anxiety-provoking label. Secondary thread: pelvic floor rehabilitation. Learn, check, train. The most directly relevant rehabilitation paper this week concerns women with stress urinary incontinence and very weak pelvic floor muscles. In this multicenter randomized trial, adding surface electromyography-triggered intravaginal stimulation to supervised pelvic floor muscle training improved strength, leakage episodes, pad use, and ICIQ short-form scores up to 12 months compared with sham stimulation. The sample was modest, with 36 participants at 12-month follow-up, but the signal is coherent. The practical point is not electrostimulation for everyone. It is rather, when voluntary contraction is very poor, an activity-triggered tool may help make training possible and more effective. The paper on vaginal palpation during early motor learning complements this. In 176 women with stress urinary incontinence who were already able to perform a voluntary contraction, adding vaginal palpation to verbal instructions and body awareness techniques did not improve fast contractions, Oxford score, endurance, or global self-perception. It did, however, improve contraction selectivity, with less simultaneous gluteus maximus contraction. This is neither an argument against touch nor an argument for systematic touch. It is more precise. If the patient can already contract, palpation may not improve global performance. If there are synergies bearing down, poor strategy, or uncertainty, it remains useful for checking and correction. The study comparing transperineal ultrasound with digital palpation supports the same logic. Ultrasound showed high inter-rater reliability and correlated with contraction-related parameters, especially proximal urethral axis angle change and levator hiatus area change. Palpation remains a direct functional clinical measure, but is less reproducible. The message is simple. The tools do not measure exactly the same thing. The hand assesses clinical function. Imaging objectifies displacement. In practice, the goal is not to find a king tool. The goal is to choose the tool according to the question. Finally, the trial of online education based on the trans-theoretical model and motivational interviewing reminds us that adherence is part of care. The intervention improved quality of life and stage of change without significantly reducing leakage frequency or severity. It does not replace training, but before asking a patient to repeat exercises correctly, we may need to work on understanding, readiness, self-efficacy, and engagement. Must read outside the dossier. The cluster analysis of fecal incontinence is very useful for clinical assessment. Using bowel and leakage diaries in 268 patients, it identified 4 phenotypes associated with quality of life and anorectal physiology. Links with manometry existed, but remained modest. The message is excellent. Urge versus passive fecal incontinence is too limited. Leakage volume, stool consistency, awareness, bowel frequency, and life impact should structure the interview. The American Brachytherapy Society report on follow-up after gynecologic radiation therapy is not as methodologically strong as a trial, but it is clinically structuring. It brings cancer surveillance, vaginal and pelvic toxicities, sexual health, dilators, estrogens, and pelvic floor physical therapy into the same field. The key message is that survival and absence of recurrence are not enough to define recovery. Tissue, sexual, urinary, bowel, and pain consequences need to be anticipated. The meta-analysis on intravaginal DHEA for postmenopausal vulvovaginal atrophy found modest but significant improvements in vaginal dryness and dyspareunia, based on 5 unique randomized trials and 1,611 participants. This is not a pelvic floor prescription issue. It is a clinical literacy point. Some dyspareunia has a tissue and hormone-dependent component that cannot be solved only by muscle relaxation or education. Useful briefs. A single preoperative dose of gabapentin, 300 milligrams, did not reduce opioid use or pain scores after vaginal apical suspension. This is a medical perioperative brief, but it reminds us that common protocol components should not persist automatically when they do not show benefit. Robotic and laparoscopic sacrocolpopexy showed broadly comparable anatomical and clinical outcomes. In observational data, robotics may reduce conversion to laparotomy. For rehabilitation, the message remains limited. This is a surgical technical comparison with little direct impact on functional reasoning. After anal fistula surgery, sexuality remains under-discussed. The review suggests gender-specific effects with dyspareunia, body image, and discomfort related to setons or scars. The paper is heterogeneous, but the clinical message is fair. Healing a fistula is not enough to document the patient outcome. In colorectal cancer, survivors with low anterior resection syndrome, a qualitative study describes the need for information, individualized support, and structured pelvic floor rehabilitation. This is not an efficacy trial, but it is a strong signal about supportive care needs, unpredictability, loss of control, strategy learning, and habit consolidation. Transanal irrigation in functional constipation showed sustained observational improvements in satisfaction, quality of life, and constipation scores up to 24 months. Without a randomized control group, caution is required, but the option is worth knowing for selected patients. The French Vigimesh registry provides patient-reported data after midurethral sling, with a median follow-up of 34 months and generally good patient-reported outcomes. Serious complications were associated with poorer improvement. Again, patient-reported outcome matters as much as technical success. In endometriosis, a high central sensitization score was associated with hormonal therapy failure for chronic pelvic pain, deep dyspareunia, and dyschezia. This is a prospective association, not proof that treating sensitization changes hormonal response, but it reinforces the value of screening sensitization mechanisms when pain persists. Another endometriosis paper suggests that the relationship between trauma exposure and pain intensity may be mediated by depression and catastrophizing rather than being a simple direct link. Because the study is cross-sectional, no causality can be inferred. The clinical message must stay clean. Do not psychologize pain, but do not ignore psychological mediators that shape pain trajectories. In provoked vestibulodynia, the tampon test showed substantial individual variability. Averaging several measures improves precision. This is a methodological brief, but useful. A single score is not always a reliable marker of change. Conclusion. This week, postpartum dominates, but not with a simplistic message. Perineal trauma should be followed through stratified care. Assisted birth and obstetric anal sphincter injury require particular vigilance. Anorectal and urinary symptoms should be screened. Pelvic girdle pain should be explained without blame. And postpartum vulvovaginal tissues remain an under-researched field. Conversely, a second-degree tear should not become a prophecy of dysfunction. The right level of analysis is the clinical trajectory. The rest of the review extends the same message. In pelvic health, visible outcomes are not enough. A graded contraction, a technically successful surgery, a healed fistula, absence of recurrence, or an improved score does not describe the whole recovery. Function, pain, sexuality, continence, lived experience, and adherence matter. This review is based on available titles, abstracts, and metadata. It does not replace full critical appraisal of the papers or practice guidelines.